When we hear someone has a broken hip, we usually think of a pretty straightforward, even if it's a really painful, injury. But what if I told you that one specific type of this break, the femoral neck fracture, is actually a high-stakes biological crisis? The moment that bone snaps, a race against the clock begins.
So why is this injury so much more than just a broken bone? What makes it so different? Well, the answer's hidden in its unique anatomy and the incredibly fragile lifeline that keeps the hip joint alive. Let's dive in and unpack one of the toughest challenges in orthopedic surgery.
Okay, so first things first, let's get our bearings. We need to understand exactly what we're talking about. Where does this break happen, and who is most at risk?
A femoral neck fracture is what we call an intracapsular break. Now, that one word, intracapsular, that is the whole story right there. It means the break happens inside the sealed, fluid-filled capsule of the hip joint. This isn't just a break out in the open on a long bone, it's a break inside a very specialized and, as you'll see, a very vulnerable environment.
As you've probably guessed, this is an injury that becomes way more common as we get older. We see it more in women than in men, and it's more frequent in Caucasian populations. But here's what's really crucial to understand: the cause. In a younger person, it takes something serious, like a car crash. But in an older patient, it can be caused by a simple, low-energy fall from just standing height.
So, the moment the break happens, a surgeon's first job is to figure out just how bad it is. They need to classify the damage, because that classification is going to dictate every single decision that comes next. Now, there are some pretty detailed classification systems out there, but really, it all boils down to one critical question: has the bone moved? If the pieces are still lined up, we call that a non-displaced or stable fracture. But if those bone fragments have separated from each other, it's a displaced, unstable fracture. And believe me, that single distinction changes absolutely everything.
So let me say that again. Displacement is everything. It's the single factor that elevates this injury from just a bad break to a potential catastrophe. And it's not just about whether the bone is stable, it's about whether or not that critical lifeline, the blood supply, has just been cut. And this brings us right to the heart of the problem. This isn't just about a bone. It's a full-blown blood supply crisis happening at the very top of the femur. This is what makes the femoral neck fracture so incredibly dangerous. Remember that word, intracapsular? Here's why it is so important. The bone is inside the joint, literally swimming in joint fluid. And crucially, it doesn't have a periosteum. That's the thick, blood vessel-rich sleeve that covers most of our other bones. That sleeve is essential for healing, and without it, this bone is basically on its own.
This slide just illustrates the problem perfectly. The main blood supply to the femoral head, that's the ball of the ball and socket joint, it comes from this one vital artery that snakes its way up the back of the bone. So when a displaced fracture happens, that incredibly fragile artery can get stretched, kinked, or even torn completely. The analogy is spot on. It's like an apple on a stem. If you break the stem, the apple gets no more nutrients.
And the consequence of that blood supply getting cut off is, well, it's devastating. It's called avascular necrosis, or AVN. The bone tissue of the femoral head, starved of blood, literally dies. This is the ticking clock that every single surgeon is racing against. So because of this huge risk of AVN, especially in older patients, surgeons are faced with a fundamental choice. It's a fork in the road. Do we try to save the original bone, or do we have to give up on it and just replace it?
For a young patient, the goal is always to try and save the original hip. Surgeons will go in and perform an internal fixation, using screws to hold the broken pieces together, and they hope that the blood supply can recover. But for an older, less active patient, the risk of that failing is just too high. The safer bet is often an arthroplasty. That means replacing the femoral head, or sometimes the entire joint, with a prosthesis.
So that just begs the question, right? In that older group of patients, when surgeons do try to just fix the bone with screws, what actually happens? I mean, how successful is it really? And the data, well, it's staggering. Just look at this. For patients over 70 with a displaced fracture, trying to fix it with screws fails an astonishing 46% of the time within just 2 years. That's nearly 1 out of every 2 patients needing another huge surgery. Now, compare that to replacement surgery. In that same group, a replacement fails only 8% of the time. This massive difference is exactly why replacement has become the standard of care for most elderly patients with this injury.
All right, so finally, let's zoom out and look at the bigger picture. Because even with the absolute best surgical care in the world, a femoral neck fracture is a life-altering event. It comes with serious risks and a really tough road to recovery.
This is a pretty sobering number to look at. Roughly 25 to 30% of elderly patients who suffer a hip fracture will pass away within 1 year. Now, this usually isn't from the surgery itself, but it shows you the immense physiological stress that the injury and the recovery place on an already fragile person.
And the challenges really don't stop there. There's non-union, where the bone just flat out refuses to heal. That can happen in up to 30% of cases. AVN, that bone death we talked about, is still a risk even after a successful fixation. And even a replacement surgery has its own risks, like dislocation. For many, the outcome is a permanent loss of at least some of their independence. So after all of this, what's the most important takeaway? What's the bottom line? Well, ultimately, the single biggest factor in determining who does well isn't the type of surgery or the brand of the implant. It's the patient's mobility and their overall health before the fall ever happened. And this leaves us with a final and I think really critical thought. We're getting better and better at the surgical nuts and bolts of fixing or replacing this joint. But as our population continues to age, the real frontier, the next great challenge, has to be shifting our focus from treatment to prevention. How do we stop these devastating falls from ever happening in the first place?